The role of genetic susceptibility is less significant in late onset Alzheimer's dementia, 15 to 25%. More on that later. We'll talk about the ApoE-lipoprotein. ApoE4 allele of the ApoE-lipoprotein is a major risk factor. And the protective factor, on the other hand, is the ApoE2 allele. Modifiable risk factors include low socioeconomic status, low educational level, hypertension, diabetes, smoking, and our topic today, homocysteine level. And protective factors like B12, folate, and B6. And we'll discuss why the homocysteine and B12 are risk and protective factors according to the cycle of the homocysteine and methionine. To be able to explain or discuss the pathogenesis of homocysteine and its effect on Alzheimer's, we have to go quickly on the pathogenesis of Alzheimer's. We have the amyloid precursor protein. This is a transverse membrane protein in cholinergic neurons in the entorhinal cortex and basal forebrain. Normally, proteolytic cleavage of this Alzheimer's precursor protein, amyloid precursor protein, is normally sequentially cleaved by alpha followed by gamma secretase releasing P3 soluble peptide. In Alzheimer's, it's cleaved by beta secretase followed by gamma secretase releasing beta amyloid peptide, which has tendency to aggregate and accumulate as amyloid fibrils, flakes, and deposits. Extracellular amyloid deposits. Here we can see the beta amyloid flakes. Extracellular beta amyloid flakes. Neurofibrillary tangles are basically, here is the cytoskeleton of the nerve cells, it's the microtubules. The microtubules is the cytoskeleton of the nerve cell. Tau protein stabilizes the microtubules. So hyperphosphorylation of tau protein causes destabilization of the microtubules and collapse of the whole nerve cell. Beta amyloid 40 and 42 are implicated. 42 represent only 10% of species of beta amyloid species in the brain, but it has more tendency to aggregate and accumulate. So we have amyloid plaques. What's the problem with amyloid plaques? It inhibits cholinergic transmission in the entorhinal cortex in the preclinical phase of disease, spreading to the hippocampus and finally to the neocortex. Amyloid plaques stimulates tau protein kinases. Tau protein kinase results in abnormal hyperphosphorylation of tau protein. As we said, tau protein is responsible for stabilization of the microtubules, which is the cytoskeleton of the cell. So hyperphosphorylation weakens the tau protein and causes collapse of the whole nerve cell. Why does all this happen? Amyloid precursor protein either increase production of beta amyloid by amyloid precursor protein or reduce clearance of beta amyloid from the synaptic left. Clearance is basically by amyloid ApoE. So if a person has two ApoE4 alleles, for example, the patient will have reduced clearance from the synaptic left, and these will trigger the amyloid cascade hypothesis and trigger neuronal apoptosis. What are the theories? Why does all this happen? Genetic, inflammatory, infectious, oxidative stress, insulin resistance in the brain. More on that later. What else does beta amyloid cause? It acts on the NMDA receptors. It causes it increases the tonic phase of calcium influx. So normally when there's a new information, there is a phasic calcium influx which allows the process of learning. So if we have tonic phase increased by beta amyloid, it starts the process of neurodegeneration and impairs the plastic processes. So it increases the tonic phase and results in excitotoxicity. So we have a patient with Alzheimer's dementia. What are the imaging modalities we can use? We can start with CT. See, why do we do CT for patients with Alzheimer's? To exclude normal pressure hydrocephalus, brain tumors, vascular dementia. The preferred modality for Alzheimer's dementia imaging would be MRI to study the 3D volume of brain structures. So what are the MRI findings in dementia? Basically, it's medial temporal lobar atrophy, parietal atrophy, and mostly hippocampal atrophy. Here we can see medial temporal lobar atrophy over time. enlarged ventricle, diffuse cortical atrophy, enlarged Sylvan fissure, diffuse cortical atrophy. The image on the left shows atrophy of the hippocampus, and more on the right side. The image on the right shows temporal lobar atrophy. This is the imaging modalities for Alzheimer's. Okay, PET and SPECT both show hypoperfusion for the SPECT and hypometabolism for the PET scan in the temporal parietal region. One of the recent PET imaging agents is the Pittsburgh compound B. It was developed in 2004. It's a non-invasive tool. It allows for imaging of amyloid fibrils through PET scan. Okay, what are the biomarkers of Alzheimer's dementia? First, the CSF. The beta amyloid 42 is decreased in the CSF because it aggregates in the cell, so it's decreased in the CSF. We have increased total tau and phosphorylated tau in the CSF. So we have decreased beta amyloid 42, increased phosphorylated tau and beta tau, and t-tau and p-tau. So we need to search for biomarkers in blood. It's less invasive, easier follow-up. So our topic today is about homocysteine. What's all this fuss about homocysteine? What's the major topic today? Homocysteine is sulfur-containing non-essential amino acid. Here is our main topic today. Methionine homocysteine site. Methionine is an essential amino acid. It's converted into S-adenosine methionine, which is the primary methyl donor for all neuronal methylation reactions. Catecholamine neurotransmitter synthesis, nucleic acid, myelin, phospholipids. S-adenosine methionine is the major methyl donor. It donates its methyl group converted to S-adenosine homocysteine. It's hydrolyzed in a reversible reaction to homocysteine. Homocysteine is either remethylated into methionine, the methionine synthase enzyme, or trans-sulfurated into cystathiamine via cystathiamine beta synthase enzyme. The major cycle will be homocysteine to methionine. This is what we'll focus on today. This reaction has a cofactor and a methyl donor. The cofactor is vitamin B12, and the methyl donor is the folate. What does homocysteine do? What's its role in neurotoxicity? It activates tau protein kinases. As we said, the tau protein, when we activate the tau protein kinase is responsible for hyperphosphorylation. Homocysteine activates one of the most important kinases, cyclin-dependent kinase 5, resulting in tau hyperphosphorylation. It also has cerebrovascular effects. Homocysteine inhibits asymmetric dimethyl arginine, impairs nitric oxide mediated vasodilatation, leads to cerebral hypoperfusion transient ischemia. This transient ischemia can lead to deposition of hyperphosphorylated tau in hippocampal neurons. As we said, inhibition of methylation reactions. How can we link this inhibition of methylation reactions to dementia? For example, cytosine phosphate guanosine residues in the promoter region of presenilin gene was shown to be increased expression of the gene when animals are hyperhomocystinic in one study. So it increased expression of the presenilin gene, reduced activity of protein phosphatase 2A enzyme. What does this enzyme do? This enzyme is responsible for dephosphorylated of hyperphosphorylated tau protein. So homocysteine reduced activity of protein phosphatase 2A. Impairs formation of phosphatidylcholine. Phosphatidylcholine is important for synaptic function and signaling pathway. Elevated homocysteine inhibits phosphatidylinositolamine methyltransferase, decreases concentration of phosphatidylcholine, impairs synaptic function and signaling pathway. Homocysteine also causes NAMDA receptor dysfunction. The tonic phase we talked about earlier, it increases the tonic phase of calcium, resulting in excitotoxicity, direct neurotoxic. Homocysteine causes oxidative stress, causes mitochondrial dysfunction. Here's a summary. Homocysteine causes oxidative stress, inhibits protein phosphatase 2A, decreased dephosphorylation of hyperphosphorated tau protein, and causes aberrant DNA methylation, inhibition of DNA methylation reactions, oxidative stress, mitochondrial dysfunction, NAMDA receptor dysfunction. As we said, vitamin B12 is the cofactor for methionine synthase enzyme, so it's important. So basically, low vitamin B12, low B6, low folate would result in high homocysteine level. This is the main point of today. So our study was aiming to estimate the blood levels of homocysteine and B12 in Alzheimer's dementia and to measure their correlation with cognitive impairment. Our study was carried on 45 participants, 30 Alzheimer's disease patients, and 15 age and sex matching healthy controls. Patients receiving B6, B12 tablets or injections and or folate tablets were excluded. Patients with frontotemporal lobar degeneration, vascular dementia, Lewy body dementia, patients receiving anticonvulsants, patients with thyroid disease, and renal failure. Complete history was taken from all patients, personal data, drug history, family history, psychiatric history, surgical history, drug history. Assessment of cognitive function was done via the Montreal Cognitive Assessment, MOCA scale. It assessed several cognitive domains: short-term memory, visual-spatial abilities, attention, concentration, and working memory, language, orientation. Blood sampling, serum, vitamin B12, and homocysteine was obtained from all patients and controls. MOCA score in all patients ranged from 2 to 22, with a median level of 12. Scores in the MOCA range from 0 to 30. A score of 26 and higher is considered normal. In the present study, all patients had MOCA score lower than 26 with varying degree of cognitive impairment. The duration of illness in all patients ranged from 2 to 9 years with a median level of 4 years. Correlations. The higher the duration of illness, the lower the MOCA score, the higher the degree of cognitive impairment. The median level of homocysteine for all patients was 24.5 u-mol per liter in comparison to the controls, which was the median level was 12.4. And there was a significant difference. All patients has high homocysteine level, more than 15. The normal range for homocysteine is between 5 and 15 u-mol per liter. The higher the patient age, the longer the duration of illness was associated with higher homocysteine level, with a more significant correlation regarding the duration of illness. There was a negative correlation between serum homocysteine level and MOCA score as expected. The higher the homocysteine level, patients with higher degree of cognitive impairment, lower MOCA score, had higher homocysteine level. Serum vitamin B12 was significantly lower in patients than in control. Patients with lower degree of cognitive impairment, higher MOCA score, showed higher serum vitamin B12 levels. Patients with longer duration of illness showed lower vitamin B12 levels. So our study, basically, first we studied the association between the serum vitamin B12 and homocysteine in comparison between the patients and the controls. There was a significant difference between both groups. So we can say that Alzheimer's is significantly associated with high serum total homocysteine level. One recent study in China actually found the same findings, and also they correlated the behavioral and psychological symptoms of dementia. It's actually the only study that studied this finding. It found a positive correlation between the behavioral and psychological symptoms of dementia and homocysteine level. The other correlation between the duration of illness with serum vitamin B12 level and homocysteine. The longer the duration of illness, the higher the serum homocysteine level, lower vitamin B12 level, and the higher the degree of cognitive impairment. Finally, cognitive impairment was positively correlated with higher homocysteine level. There was a study that found no relation between total homocysteine and cognitive impairment. They used different study design. Their study was a longitudinal prospective study. Our study was a case control study. And they used mini-mental status examination, different psychometric tests, instead of MoCA scale used in our study. A study in Sweden, Mattsson and his colleagues hypothesized that lower cortical gray matter thickness in the parietal and temporal regions, the areas implicated in Alzheimer's, they correlated the MRI findings with the homocysteine level, and they found a positive correlation. They found thinner cortical gray matter with higher homocysteine level. In our study, we did not make any correlation between MRI and homocysteine levels. Our study was a case control study. It cannot prove causality. It can be argued, for example, that patients with Alzheimer's reduced intake of vitamin B12 or has reduced vitamin B12 concentration, and this is the cause for elevated homocysteine level. So we cannot refute this possibility in this case control study. But we recommend further longitudinal study to study the difference between baseline homocysteine years later, and correlate this with cognitive impairment, functional imaging, and MRI findings. Also, longitudinal studies measuring the effects of folic acid, vitamin B12, supplementation in reducing the risk, delaying the onset, as well as progression of Alzheimer's. Finally, hyperhomocysteinemia can be used as one of the biological markers and can be considered as one of the risk factors of Alzheimer's dementia. Thank you very much.